Hi everyone, my name is Holly Hood and I'm the Program Service Coordinator here at the Chromosome 18 Registry and Research Society. We hope you're enjoying our conference so far. We had a great welcome session with Rick with Positive Exposure. And now you are in the session called Movement Disorders with Dr. Atkinson. He has a wealth of knowledge. We hope that you learned a lot and enjoy this session. I do have a quick joke for you before I get to our announcements. Why can't Elsa from Frozen have a balloon? Anybody? Because she'll let it go. Just to remind you, we will pop a few links into the chat box if you're interested in our silent auction that is now open, our merchandise, or if you're interested in getting a table for the family touring event tomorrow. Before we get started, I wanted to share a little bit more about Dr. Atkinson. He is a child neurologist who retired from the military after a long and successful career to embark on a new adventure as Chief of the Child Neurology Service at the University of Texas Health Science Center at San Antonio. He has taught child neurology to residents in pediatrics and neurology in several programs of the Army, Air Force, and at civilian institutions, and has had extensive management and leadership experience in the Army Medical Department, Tri-Service, and Veterans Affairs roles. Dr. Atkinson, co-founder of the Chromosome 18 Registry and Research Society, has also won awards for clinical teaching excellence at several institutions. He has been active in the Child Neurology Society for over 25 years. He also enjoys playing with his grandchildren and spending time with his Boy Scout troop in his free time. Dr. Atkinson, thank you so much for sharing with us today, and without further ado, we will go ahead and get started on movement disorders with Dr. Atkinson.
Okay, hello folks, my name is Dr. Sid Atkinson. I'm the Chief of the Division of Child Neurology and a few other things. And we're going to talk today about movement disorders. Now, I have nothing to disclose. I don't have any financial interests in anything that would be untoward, so I am going to just say nothing to disclose. The purpose of my discussion is to give you an overview of movement disorders in children. In children, these can be inherited, they can be an autoimmune disease, they can be part of cerebral palsy, or they can be part of other brain injuries. So I'm going to go through a few of these with you now over the next few minutes. The term movement disorders refers to a group of nervous system or neurological conditions that cause you to have abnormal movements, abnormal voluntary or involuntary movements, or slow or reduced movements. An example of two things that most people have heard of, Tourette's syndrome is an example of hyperkinetic or increased movements. Most people have heard of this syndrome and they think of the involuntary cursing, but honestly, I don't see that very often. And the times that I have seen it, I really think the kid that I'm thinking of decided he wanted to say ugly things about his mother, and so he used to use wonderful terms like stupid bitch and other things like that when his mother would say something. And I don't believe that he really had involuntary cursing, although that's what you hear about Tourette syndrome. The most common presentation is actually facial or shoulder or head and neck tics, although they can have involuntary tics of the diaphragm, which when they will exhale and make a noise, but it's not cursing. So that's an example of a hyperkinetic movement disorder, which children typically get. By hyperkinetic, I mean increased movements. Parkinsonism, most people think of Parkinson's, they think of the tremor, but the fact is that in Parkinsonism, most often in adults, and seems to be an autoimmune problem, but it can happen in children, by the way, with certain types of drug usage. But Parkinsonism, the biggest problem, honestly, is decreased movement. You have the inability to start movements. So, for example, someone with Parkinson's disease, although they may have the tremor, that's not the characteristic thing. The characteristic thing, honestly, is for them to be unable to start movements. So they will have a very flat face. They have trouble swallowing. They have, when I say a flat face, just no expression. You know, we normally, all of us make a lot of expressions as we talk in our facial movements, and these people cannot do it. And they will do things like, for example, to start walking, they will have to lean themselves forward, and then finally their foot will swing forward. They can't voluntarily do it. So Parkinsonism is a hypokinetic movement disorder. Tourette syndrome is a hyperkinetic movement disorder. Now, movement disorders come from a special part of the brain. So these things include hypokinetic rigid and hyperkinetic or mixed forms. Most of them originate from the dysfunction of the basal ganglia and their information circuits of the basal ganglia. The functional anatomy at the base of the basal ganglia, the cortico-basal ganglia, thalamocortical and basal ganglia cerebellar circuit connections. Now that's a mouthful, and what I mean by that is that the basal ganglia is involved in automatic movements and in smoothing out our movements. When I want to throw a baseball, I do not have to think, well, I may plant my left foot and push off with my right, rear my right arm backwards and point where I want to go, and then move my trunk and leg. I just think, where does I want the ball to go? And the basal ganglia incorporates all of that for me, and I don't have to think about it. The cortico-basal ganglia, thalamocortical, which is the cortex is where you think, basal ganglia, and then the thalamus is involved in other sensations mostly, and so it'll tell you where your body in space is. So, for example, to try to explain that one, if I'm walking down the hallway and while I'm walking, I'm also tossing a ball to my other hand and back to the first hand, I don't have to think about where that ball is going. I just have to do it. And my brain will automatically tell my body, move my hand forward to catch the ball and then move it, and I can toss it to the other hand. And I don't have to look at it. I can just do it automatically. That's what I mean by automatic movements. The cerebellar circuit, the basal ganglia cerebellar circuit, the cerebellum is involved also in smoothing out movements and integrating them. If you don't have cerebellum function, you have a tremor and you are unsteady. This is what the police will do a drunk screening on you, and if your cerebellum isn't working because it's had too much alcohol exposure, then you will have a tremor, you will have unsteadiness, you will fall. That's what the cerebellum does. Again, automatic movements without you having to think about it. So basal ganglia, I'm going to show you a picture of the basal ganglia here in a second, but right now remember that these come from a certain part of the brain, and that area of the brain can be affected by a lot of things. So the pathophysiologic classification of extrapyramidal movement disorder mechanisms distinguish Parkinsonian syndromes, chorea and related syndromes, dystonias, myoclonic syndromes, Ballism, tics, tremor syndromes, recent genetic and molecular biologic classifications. I tried to leave that word out, but anyway, synuclein nucleopathies. The point I'm trying to discuss here, Parkinsonian syndromes, we've talked about. Chorea is involuntary jerk-like movements. Dystonias are bad muscle tone. People will have turning of their arms or legs or cramping of those muscles, and they will be painful and difficult, and you will see people have involuntary movement that is of a muscle group. So, for example, sometimes you may feel it in your thumb will move into your palm, and it can be uncomfortable. Usually dystonias are painful. Myoclonic syndromes are just random muscle jerks. Ballism is larger involuntary jerks. where it's involving most of your body. Tics, we all have tics at one time or another. Every time I get truly stressed out, my eyelid will twitch on one side. I forget which one it is. And then tremor syndromes. Most of you have seen tremors. Basal ganglia is deep inside the brain. It's got projections from the cortex down to it, and projections from it to the cortex, and then down to the brainstem, and down to the spinal cord, where these messages will get sent, and the movements will either be integrated or they will be non-integrated, which is what the dysfunction of the basal ganglia is. Basal ganglia is a group of subcortical nuclei of varied origin in the brains of vertebrates. They're associated with a variety of functions, including control of voluntary motor movements, procedural learning, habit learning, conditional learning, eye movements, thought, and emotion. So one of the things that you need to remind yourself is a lot of times people with movement disorders also have emotional problems. And they may have some level of cognitive problems too. Parkinson's often have an associated dementia. Okay, I'm going to move on. The example of a movement disorder, ataxia. That's affects a part of the brain that controls coordinated movements. It's in the cerebellum, and it may cause you to be uncoordinated. An example of ataxia is when you are, for example, inebriated and you can't walk a straight line. That's ataxia. Clumsy balance, speech or limb movements, and other symptoms. Another one is if you try to think of taking a screwdriver and inserting it into the slot of a screw, somebody with ataxia would have one very, very difficult time doing that, although the rest of us can do that reasonably. Cervical dystonia. Remember, dystonia is muscle contractions that you don't want. And a lot of people will have cervical dystonia. People have heard of it called, what's the term I'm looking for, where your head turns to one side. Anyway, cervical dystonia, and these are long-lasting contractions or intermittent contractions of the neck muscles, causing the head to turn one way or another. But dystonia doesn't have to be limited. I'm sorry, the word I was looking for is torticollis. But the cervical dystonia doesn't have to be limited to the cervical region, the neck. It can be in any part of the body, and there's certainly a syndrome in children that's inherited, and which occurs in all of the body, and it's very painful to watch these people have these writhing muscle twitching or contractions that are painful and take over their ability to move. Chorea is associated with brief, repetitive, irregular, somewhat rapid, involuntary movements that typically involve the face, mouth, trunk, and limbs. Dystonia. That's what I've been talking about several times, sustained involuntary muscle contractions with twisting repetitive movements. It may affect the entire body, and generalized dystonia, or one part of the body called a focal dystonia. It's a really difficult diagnosis, very painful, and it can be associated with cerebral palsy when you have damage to the basal ganglia from anoxic brain damage, which can be a part of cerebral palsy. We typically would call that dystonic cerebral palsy, and it's really painful to watch these kids do it. Functional movement disorders means that the person is either pretending or having a hysterical reaction. Hysterical means you don't know you're doing it, but it is not a true movement disorder, and these can be difficult to tease out. I get consults every year from people who can't recognize that the kid's trying to get out of school or get away from a difficult situation at home or at school or in some other social group, and they will pretend to have a movement disorder. And these can be hard to break out because they're so similar to other movement disorders. Huntington's disease is a type of inherited progressive neurodegenerative condition that causes uncontrolled movements, chorea, impaired cognitive abilities, and psychiatric conditions. This is a tragedy in that it usually hits people in their 30s after they've already had children. Now, one of the things about Huntington's is that in succeeding generations, it tends to come on earlier by a process called amplification, where the disorder that is in the genes gets larger as time goes by, not in the first person, but as they pass this condition on, the defect will be larger in the gene itself, and so that the condition will come on at an earlier age. I have seen someone who great-grandparent had it in the 50s, grandparent had it in the 40s, mother was in her late 20s, and kid was 9, and all had this terribly ravaging disease, Huntington's, which is progressive, fatal, and degenerative. There's something called multiple system atrophy. It hits adults, doesn't happen in kids. Uncommon progressive neurological disorder that affects many brain systems, and it may cause a movement disorder such as ataxia or Parkinsonism. I think we've talked about myoclonus a couple of times, but let me go over it again. Lightning quick jerks of a muscle or a group of muscles. So if I see someone who has myoclonus, it'll often be a group of muscles that may be a twitch of the head, maybe a twitch of the neck, but it's usually the extremities that I see it in, and it'll be a twitch. It can be a repetitive twitch and can look for all the world like epilepsy. And to be confusing, myoclonus just means muscle jerk. And so we've actually in neurology confused the heck out of ourselves by thinking of a myoclonic epilepsy, and believe me, there is a myoclonic epilepsy. And then brainstem damage, myoclonus, damage in the spinal cord, which gives you a local or a focal myoclonus. And then there's the all over different parts of the body, just myoclonus. Parkinson's disease, we've talked about, again, slowly progressive neurodegenerative disorder caused by it, which causes a tremor, stiffness, which is the rigidity, slow decreased movements, or bradykinesia or imbalance. It may also cause other non-movement disorder symptoms like Parkinsonian dementia. Well, some people have heard of restless leg syndrome. It's another type of movement disorder which causes an unpleasant abnormal feeling in the legs while relaxing or lying down, oftentimes asleep, and is often relieved by movement. But if it's happening to you while you're asleep, your partner will let you know that it is difficult for them to lie near you. I don't know about you all, but I certainly was one of those kids. My brother didn't want to sleep in the bed with me when we would go on family trips because I moved all the time. Thank God I don't do that anymore, and I don't really know that I had restless leg syndrome. Another more difficult one we're going to talk about a couple of times is something called tardive dyskinesia. This is a condition brought on by the long-term use of certain drugs, which are used to treat psychiatric conditions. Unfortunately, these same drugs are often used to treat movement disorders, and I'll get into that a little later. Remember Tourette syndrome, and Tourette syndrome is a neurological condition that starts between childhood and teenage years and associated with repetitive movements, motor tics, and vocal sounds, or vocal tics. The true definition of Tourette syndrome is presence for 3 months or more with a waxing and waning, in other words, gets better and gets worse, course of complex motor tics involving several muscle groups, not just your eyebrow or your eyelid, as most of us have tics at one time or another, especially when we've been stressed for some period of time. And most people will actually have tics, but you don't go on for 3 months. You don't have it get better and get worse. And you do not have to have vocal sounds to actually have Tourette syndrome. The other thing, if you remember back to when I was talking about the basal ganglia, it has psychiatric conditions involved in that. And Tourette syndrome, a lot of these kids will have psychiatric syndromes like obsessive compulsive disorder. And they can be really difficult. That can be more disabling than the tics. In fact, what I tell parents is that Tourette syndrome is not a disabling condition. You are not physically disabled by it, but it may be a socially disabling condition, and you become absolutely impossible for you to exist in a classroom or for other people to tolerate your crazy movements. An example of that was I had a young girl some years ago whose mother braided her hair into little 1-inch squares, and at the end of the braid she would put a barrette, so the kid would end up with 30 barrettes or so throughout her hair. And you think, well, what's the matter with that? Well, she had Tourette's, and every time she would shake her head, it would make noise because the barrettes would make noise. And so this mother, I said, you've got to take these barrettes out of her hair and let her have a different hairdo. So we were able to avoid medication because I simply said, this is what I need you to do to make this child acceptable socially, because she was bothering all the kids around her and they teased her horribly. Just removing the barrettes solved the problem. Tremor, a lot of people understand tremor. It's involuntary shaking, usually rhythmically of parts of the body, hands, head, or other parts of the body. If you think of the movie On Golden Pond, the famous actress who was a star in that had it in her voice, and she also had it in her head. But most people have it in their hands, and if you ask them to stretch their hands out in front of them, they will tremor back and forth, and you'll be able to see that. They also may be the kind of person that when you say, can you take a screwdriver and put it into the slot on a screw, they would say, no, certainly can't do that. Some types of tremor get worse when you try to do that kind of thing, and actually we differentiate those. We call that an intention tremor, where when you intend to do something with tight control and it gets worse, we call that an intention tremor. And then there's a tremor at rest. And if you have those people then try to move, their tremor may disappear briefly. Wilson's disease is another inherited condition that causes excessive amounts of copper to build up in the body and build up in the basal ganglia, and it causes a movement disorder, and again back to psychiatric disorder, and unfortunately it dements you slowly. We tend to call it dementing because although you might think of mental retardation in children, not dementia, it gets progressively worse, so we talk about them dementing. Now, my reference on this is the Mayo Clinic Movement Disorders page. You can certainly go there and read a great deal more about movement disorders, and I recommend that to you. All right, some of you have heard of something now. I will tell you that the Mayo Clinic doesn't have anything about Pandas in it. Pandas is one of the more common movement disorders of childhood. It's not clear to me that this is new, although it's newly described. I think back 100, 150 years ago, they called it chorea from strep, and it was often called Sydenham's chorea. after a doctor who described it. So we have Sydenham's chorea that was famous and well described more than 100 years ago. Hardly ever see it now. I've seen 2, maybe 3 cases in my long career as a neurologist. But Pandas stands for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Streptococcal Infections. Again, look at those words, autoimmune and neuropsychiatric. So that remember that they have behavior disorders and they have psychological and psychiatric effects. That child may be diagnosed with Pandas when obsessive compulsive disorder, tic, or both suddenly appear following a strep infection such as strep throat. We can usually find that you had evidence of a strep infection by measuring antibodies in your system to strep bacteria. It sometimes can be more difficult than that, and there's actually another physician in Oklahoma who's come up with a wonderful test called the Cunningham panel. And if you believe that you might actually have Pandas or a family member have Pandas, that's probably the best test to get. You can search online to find the Cunningham panel. Again, certainly a not well agreed upon syndrome. In fact, what I want to tell you is that a colleague of mine at Johns Hopkins named Harvey Singer, Harvey has spent years trying to prove that Pandas doesn't exist. I think it does, and I think he's wrong on that. And I think that you've got good evidence for it, like the Cunningham panels. But what we've noticed is that it really seems to cause these things, and I don't think they're all Sydenham's chorea. I think there's a separate diagnosis called Pandas. So what causes Pandas? Strep bacteria are a very ancient organism that survives in the human host by hiding from the immune system as long as possible. They hide themselves by putting molecules on their cell wall so that they look nearly identical to the molecules found on the child's heart, joint, skin, and brain tissues. Please note that. Now think about the heart disease. Why do we give penicillin for strep throat? We give it to prevent rheumatic fever or heart disease from strep infections in children. Kids can also get rheumatic fever and have joint inflammation and joint problems. They can have lesions on their skin, and it can affect the brain, Sydenham's chorea, or Pandas. So strep is very common, as you know. It can be passed around among your family for years at a time. Mom may carry it in her nasal passages, her sinuses. Dad may get it, and it may go throughout family member to family member for up to several years at a time. And then when somebody gets a virus that lowers their resistance to infection, strep will pop up and cause this problem. Now, could an adult develop Pandas? It's considered a pediatric disorder and typically first appears in childhood, but it could occur among adolescents and maybe even adults. One of the things to notice is that strep infections are fairly rare after age 12. Okay, so less likely, but it probably can occur in adults and certainly in adolescents. Now, what I'm seeing more of is not necessarily Pandas, because all the strep tests are negative, but we're seeing viruses that will cause an autoimmune disorder. And so you get a viral infection, a few weeks later you develop this movement disorder, and you are having serious movement, crazy types of movement that you've never had before. Lots of times these are not understood, not recognized. Now these can be paraneoplastic, which means that you actually have a cancer in your system, or they can be perinfectious, which means you've had an infection and then it's come on. And these presentations can be weird, diverse is what they mean. We're not saying weird. And multifocal, in other words, multiple parts of your body. Autoimmune movement disorders are rare. I'm seeing probably 3 or 4 a year, but they're potentially treatable, and they can present usually with an excess of movements. They could present with a paucity of movements, in other words, fewer movements than more of a Parkinsonian picture, but I just haven't seen that yet. They may have other associated neurological symptoms. A lot of the kids will develop, like in pandas, an obsessive compulsive issue. These disorders were originally recognized by their classic clinical presentations and the cancers associated with them, but it doesn't have to be cancer. Now, treatment of movement disorders. So I'm going to start with the acute treatment of an autoimmune movement disorder, and then the chronic treatment, surgical management, and when to use Botox. So let's start with the acute treatment of an autoimmune movement disorder. I typically do that when a child has a brand new onset movement disorder and the clinical situation points to an autoimmune cause. I can often get a history that within the last 2 months they had a viral infection. Sometimes it was barely apparent, but I can usually get the history. And then I will tend to give them intravenous immune globulin and or prednisone. I like to give them intravenous immune globulin. It is fairly expensive, and I usually have them in the hospital. I will do a spinal tap to see if they have a more severe form of this autoimmune encephalitis. But sometimes they have no signs of inflammation in the spinal fluid. They will just have these new onset movement disorder. I've had kids that did things like had a weird tick of their body where they bent to the left or bent to the right, other ones where they bent forward. And you think this is all being faked. And remember that I said that functional movement disorders can be confusing. These may look fake, but in fact, the kid has this syndrome. Intravenous immune globulin can clear it up often fairly quickly. This intravenous immune globulin also works for pandas, by the way. Prednisone is a steroid anti-inflammatory drug. We can give it orally, although sometimes we'll give it intravenously to start you, because we'll give a very high dose for 2 to 5 days. And again, that can dampen down the autoimmune response. All right, I'm going to move on. Chronic therapy is challenging, and the most effective drugs have significant side effects. So usually we will start with a benign drug like clonidine. I don't know if you all know clonidine. Clonidine has some fairly minor side effects. It was developed as a blood pressure medicine. So back in the 70s when I went to medical school, I was taught clonidine, you give it orally or you give a patch, it'll lower the blood pressure. And then they noticed that it seemed to have effect on Tourette syndrome and other movement disorders. So it is often used. It is not as effective. In fact, there were some articles at one point that tried to prove it wasn't effective at all, but it really seems to work. The biggest side effect is it does make you sleepy. And in fact, I probably use more clonidine to help kids with autism and other conditions where they don't sleep have easier onset of sleep. Sometimes I even have to have the mother give it twice during the night, once at bedtime and once at midnight, so that the kid will stay asleep. But we use more of it for sleep, but it does work for movement disorders, and it doesn't really have a lot of side effects except lowering your blood pressure or making you sleepy. The more effective but risky therapy, and I have to do these at times, is to give haloperidol, known as Haldol, or risperidone, known as Risperdal. These have significant risks of side effects. And all of these that I'm mentioning, weight gain can be significant. 10, 20, 30% body weight increase, which is a lot. Breast tissue enlargement, to the point where they not only enlarge breast tissue, it becomes noticeable, especially in boys where they will develop breasts and can get teased about having boobs. But worse than that, it can stimulate prolactin formation in your pituitary gland. And I have had one child that was on this for control of his autistic behavior, and he developed a prolactin benign tumor in his pituitary, and we obviously had to stop the use of the Risperdal. It also can make breast milk production in boys and in young girls. So not a minor problem, but the worst one is something called tardive dyskinesia. And I mentioned that earlier. Tardive dyskinesia is a weird disease. Tardive, late onset, dyskinesia, bad movements. There's a wonderful website, if you will go on Google and search it, and it had videos of what the movements can be. That can be often in the face. You'll have twitching of the lips, but it can be any part of the body. They actually showed people where it was in their feet, and their feet looked like there was restlessness among them, and you'd think, well, maybe they're just doing that. But these things tend to go on involuntarily against your will, and you get tired of them. And there are other side effects of the use of haloperidol and risperidone. Now, the weight gain is early on and significant. The breast tissue enlargement is worse with Risperdal, less with Haldol, but the sedation is more significant with Haldol. And then there's one I don't tend to use very much called olanzapine, which the breast tissue enlargement is less, but it has other side effects. So unfortunately, these are drugs that are very effective against movement disorders, especially Tourette's and other hyperkinetic movement disorders, but not easily used. And the tardive dyskinesia, I've been doing this for 40 years. Fortunately, I've never seen a case of tardive dyskinesia that I've caused by treating Tourette syndrome or other movement disorders, but certainly read about it, and I'm frightened by it. It tends to develop after years of use, and usually for psychiatric conditions, which are often have much higher doses than I would ever use for a movement disorder. But I'd encourage you to read about tardive dyskinesia before you ever consider use of either one of these drugs in your child. Now, there's another treatment called a deep brain stimulator. You say, whoa, what's that? Well, this is not to be used lightly either, and I've had a couple that I put in, one for a kid with cerebral palsy that had severe movement disorder, another child that had a hereditary dystonia, and her body head would turn to the left, and her body would just contract in awful ways, and we put a deep brain stimulator in her. It helped her tremendously. And then I had a third child this one is older. She's now in her 20s. And I put that in her. I had my neurosurgeon do it, a deep brain stimulator, and it achieved tremendous success. Unfortunately, it doesn't solve all of her problems, so I do have to give her Botox as well. And I'm going to now go on and talk about Botox for a minute. Before I finish, I guess I'm going to talk about deep brain stimulation a little more. Deep brain stimulation is a surgical procedure that involves implanting electrodes in the brain, which deliver electrical impulses that block or change the abnormal activity that cause the symptoms. The deep brain stimulation system consists of electrodes that are implanted in the brain and other components to support it. There's a generator that sits under the scalp over your skull, and then of course the wires and the programming receptor. We can use a magnetic device that communicates with the deep brain stimulator, and we can program it to change, to increase or decrease the signal that's sent to the brain. But this is put into the thalamus, remember I talked about the thalamus earlier. It's not one of the basal ganglia, but it is next to them and connects with them heavily. So it's put into the thalamus, and it achieves tremendous improvement. Botox, it's a therapeutic drug made from the bacterium Clostridium botulinum. It's often used to temporarily smooth facial wrinkles, but it can also be used as an effective treatment for some medical conditions, including movement disorders. So that 20-some-year-old that I was talking about that has the dystonia so bad from her cerebral palsy, her toe on one foot curls down and under, and to the point where she had worn calluses right next to the toenail. It would curl under and she would have to walk on it. Now, if I give her Botox in the toe, it allows that muscle to relax, and she can walk. She can walk much more normally than allowing that foot to curl as it does. I'm sorry, she can't walk normally. Please don't think that, because she is still cerebral palsy and has the movement disorder with dystonia. Okay, so that's what I have to talk to you about today, and I'm going to finish with that. If you have any questions, you'll have to email me, and I'd be happy to answer any questions that you might have. I've had fun being here today, and I would like to also announce that I'm considering retiring in the next 12 months, so this may be the last time I get to talk to you all. Anyway, God bless all, and good luck. Thank you.
All right. Thank you so much.